see people here. I always have these fears when I do these talks that no one's going to show up. So what's very interesting about Chris's presentation is I'm a pharmacist, I'm a researcher, and a lot of what I've been working on is how do we make digital health tools more accessible. Now, as a pharmacist, I focus on medication, which means that I have been forced to think a lot about security. For example, on our research team, we now work with a cryptographer. I didn't even know what that was until I started working on this. So for me, the whole issue with digital health tools is that we have two main issues. One is that there's the security, privacy aspect of it. The other side, though, is that we have tools that are not accessible. So this is about how do we make these things more accessible. So I'm going to talk about three things. The first thing I'm going to talk about is what I think of as mHealth versus mHealth care, what we're doing in our own research, and then the 5 lessons that I've learned, and there's probably a million lessons I've learned, mostly through failure. But these are 5 lessons that I'm hoping you can take home. So just a show of hands, how many people in here are patients? Okay, and how many people here are health professionals? And how many people are researchers? And developers? And anything else? Media, perfect. Everything, health, insurance? Okay. So this is my last slide, and my take-home message is this, is that to make an impact, we need mHealth to be mHealth care, and here's what I mean by that. Healthcare covers us from when we're born until when we die, if we're privileged enough, obviously, to afford healthcare. I'm from Canada. I'm from the University of Waterloo, where, yes, and I do see some familiar faces, that's right. So I'm from about an hour west of Toronto. And certainly for us, healthcare is a right that we have from when we're born until when we die. Now, if we look at healthcare spending, there was a great talk yesterday where they were talking about how we just don't know how much things cost. I think Vivian Lee was talking about that. So half of Ontarians in the province I'm from are responsible for 1% of healthcare spending. This is in a publicly funded health system. 5%, or 1/20th of the population, is actually responsible for 66% of healthcare spending, or 2/3 of all healthcare dollars go to that population. This is 2007 data. Now, here in the US, this is from, I believe, 2002, half of Americans are responsible for about 3% of healthcare dollars, and 5%, or that 1/20th of the population, is responsible for around half. And yesterday, when Ann Lindsay was talking about the Stanford Coordinated Care Program, she used the number 10% of 10% of the population is responsible for 2/3 of healthcare costs. So the take-home message is that a small fraction of the population is actually what's responsible or what's spending those healthcare dollars. Now, when we look at those populations, they vary, but often these are people who are lower income, lower literacy, multiple health conditions, multiple medications. So again, I'm a pharmacist. This is something we focus on. These are often patients who have 20 or more medications, right? So they're on a lot of medications. They often have mental health problems as well. So we have something now in Ontario called Health Links, which is focusing on that 5% of patients. A lot of those patients are low income, mental health, multiple medical conditions. They're incredibly difficult to support and help and very resource intensive. Now, mHealth covers us from birth until illness, in my opinion. Of the 43,000 mHealth apps that are out there, this is the IMS data looking at iTunes apps, 1 in 3, so I think it was roughly 16,000, are directly related to health and treatment. So the other 2/3 were not really, they're more wellness apps, not health and treatment apps. So of this third of apps, 4 in 5 simply provide information or instruction to us. They tell us what to do. It's not tailored to who we are, they're simply giving information in various ways. And about 1 in 5 collect data. What's missing are apps that are collecting data and using that to give us information. Right, that's a major gap here. So today's mHealth we also need to consider is for the relatively wealthy. So a lot of apps are actually being built, for example, for the iOS operating system. Now, if any of you have actually worked with patients, for a long period of time, and you'll notice a lot of your patients coming in are not people who are going to have a lot of money and who are going to go out and buy the newest iPhone. Their first stop might be to go out and buy the Google Nexus tablet that was $200 at Walmart. Not the $700 iPad or $900 iPad at the iTunes store. They might not even know that exists, or they may realize they don't need that. But what that means is as mHealth tools are built for that very specific iOS platform, they're actually missing a huge section of the population that can't afford that technology, but can afford something else, say an Android-based system. I'd argue, too, that it's being built for the relatively healthy. So I work in med management. When we look at med management apps, what's great, what's funny, is they're often being built for young women on birth control. And let's think about this, because birth control, these women want to be compliant. They don't want to get pregnant, right? So they have a really big incentive to take those meds every day. The other side of that is they're taking meds out of packages built for compliance. Right? They've got days of the week. They can follow when they miss pills. They've got strategies for when they miss a pill. That's not the typical patient I see when I'm in the pharmacy, or if I'm in the emergency department, or if I'm in the hospital. So what we're seeing is that mHealth, again, is being built for people until they get sick, not once they're actually sick. So a different way of looking at that is if we look at the 95% of people who in Ontario are spending a third of healthcare dollars, that's what mHealth is covering. What I'm interested in is that 5% who in my province is responsible for 2/3 of healthcare spending, and that's what I'm calling mHealth care. Which brings us to the digital divide. So if we look at the digital divide, and the best way to look at this right now, in my opinion, is looking at internet adoption. So what we see is that, sure, younger people adopt the internet more than older people. But if you actually get deeper into the data, what you see is it's not really about age, it's actually more about income. So the biggest predictor of internet adoption is going to be income. So older adults who are wealthy are online. Older adults who are not wealthy are considered non-liners. Right? The other things we look at there, though, is literacy. People who have high literacy are more likely to be online. People with low literacy are not likely to be online. People with higher levels of education are more likely to be online. People with lower levels of education are less likely to be online. So our so-called non-liners may be older, but they're actually people of lower income, lower literacy, and lower education. When we design for mHealth care, we need to remember that that's actually our patient population as well. This came up yesterday that 95% of patients will have a cell phone with text messaging capability. Why are we not harnessing that? And that gets into the fact that we see when women come out of prison, for example, one of the first things they get is pay-per-use phones. And their primary means of getting in contact with those around them is pay-per-use cell phones. Text messaging, it's a great way to keep in touch with them. So we need to remember that age is not the only explanatory variable for adoption or non-adoption. We also need to consider that our individual differences increase as we age. And so I love this picture because it's about fall. I'm Canadian, we're getting into the fall now. And so what you see is in the spring, your leaves come out, they're green. You get in, bright green. You get into the summer, they get to be a darker green. You get into the fall and you start to get yellow and gold and orange and red and brown and purple, burgundy. So what they refer to this when we're looking at digital divide is you get a fanning out of differences. As we age, we become very different from one another. So we need to consider age-related physical changes. So it's not being old. It's that as I age, my hearing is impaired. So I see this a lot with men who have worked with heavy machinery. Those iPad alarms, they can't hear them even when they're in front of them. So don't build an app for them that's going to remind them using an iPad alarm. They can't hear it, even if it's right here. And you say, whose alarm is that? What alarm? That one, right? What? Right there. Where? So we see this a lot. The closest you can get is a phone that goes in the pocket of a shirt, for example, right? They might be able to hear that because it's by their ear, but that's a bit of a stretch. The other thing we see is as you age, you lose your ability to see low contrast. So yellow on white's not going to work. Gray on white, it's not going to work. You need black font on white background. If you have low vision macular degeneration patients, you need white font on a black background. So part of it is actually getting up and spending time with them. The other thing you lose is your ability to see glare. So magazines, but what we now have are iPads, iPhones, Samsung Galaxies, whatnot. Those have a lot of glare. That can be a big problem for people. We also have problems with cognition and mobility. So an oscillating tremor, whether it's Parkinson's or an essential tremor, can make it actually very hard to activate that screen. So one thing that really helps for us is really inexpensive styluses. You can buy them at the dollar store for a couple of dollars, or teaching them to use a swiping motion instead of a tapping motion. That actually can make, it's very simple, but it can make a big difference. We need to consider, too, that somebody might actually be a really engaged early adopter who simply cannot afford to be an engaged early adopter. So having 2 small kids, I've gone through maternity leave in Canada. Very privileged to have a year-long maternity leave. Also means that for a year, each of us gets to live on employment insurance, so about $1,500 a month. And so you don't buy an iPad that year. You wait till you're back at work. Now consider, though, that people on a pension live that way all the time until the end. They may really want to adopt technologies, but simply can't. So we need to design for affordable technologies. Again, a $200 tablet is accessible. A $700 tablet is not. So here's some of the research we did briefly. So one was we looked at medication management apps, and I started to think, I'm not 100% sure about this, if this is going to work. So we picked 4 that we thought represented a nice spectrum: reminders, information, drug interactions, visual pill cabinets versus just list-making hierarchical menus. We invited people over the age of 50, gave them some standardized medications, and that's where we learned this issue about the fact that every one of them had a reminder, and every group we had, people could not hear the reminders. That was a huge take-home for us. So then we went to the developers and said, who did you talk to? And they said, oh, well, friends and family, as you do. Okay, well, I work with a lot of people who take pills. Did you talk to them? No, not really. So kind of a take-home message there, right? Talk to your user. This is one that we tried to design, which was really interesting. 50% of people cannot read or understand a medication label, so we tried to create a screening tool you could use in the pharmacy to identify those people. We had pharmacists engaged as our end users. They were involved throughout the whole process. We went out and studied it. Even the pharmacists who were engaged, when it actually got launched in the pharmacy, they never used it. So we floundered for about 4 months, and then we went to retirement homes. They loved it. They loved it. Our oldest was 94. Well, this is cool. I've never seen this. They had iPads. What we realized was that we were trying to make pharmacists care about an issue they didn't care about through an app, and that's where we had failed. Patients loved it because all those patients had this problem, and they were never being asked about it by the pharmacist. An app wasn't going to make them care. Then I had activity trackers. I started this by giving my in-laws, who have regular health issues, they probably don't exercise enough, don't eat as well, and said, well, you try this and you tell me. So my father-in-law now calls his Fitbit his Fitbitch because it gets him moving. But what's interesting is when we actually started to study taking this to people over the age of 50, the take-home message they gave us was they didn't know these things existed. They would only know if we put it in the pharmacy. Why can't you give us a tax incentive? So I went to the Canada Revenue Agency and I said, can we get a tax incentive? They said, yeah, sure. If a pharmacist or a physician prescribes this, you don't have to charge tax on this. This is actually, you can take this off of their taxes as well. This was news to us. They didn't go to Best Buy and Future Shop. They go to the pharmacy. So here's my quick lessons. First thing, if you're working with someone who's older or new to this technology or who's not very engaged, the first thing you say is, don't worry, you're not going to break it. Over and over and over again. Don't spill coffee on it. Don't throw it on the linoleum. Beyond that, you're not going to break it. We can fix anything you do. Learn through trial and error. Just play with it. I learned this from an older, very frail patient who's in his late 80s, tried an app for us, and then he said, can I play Angry Birds? And that's how he'd learned how to use the iPad. Games are a great way to teach them how to actually touch. So older adults, we find, tend to hold down too long, because if something's not working, they press harder and harder, then they activate copy-paste functions, they think they've frozen it, it's all gone to hell, and they don't know what they're going to do. Well, a great thing to do is give them a game, and then they can learn those swiping motions, how to touch lightly. Instruction manuals, this is the bane of our existence. They're not out of style, contrary to Apple's approach to giving a beautiful box and a beautiful package with no instruction manuals. For things like wearable trackers, instruction manuals are essential for older adults to get engaged. They can learn through trial and error when you give them instructions that give them the latitude to learn through trial and error. So make sure that something is usable by making it visible and audible, by working with your patients to know what they can see and what they can hear. And finally, know your user and know who your user is not. We work in medication management. If you are working in medication management, for example, you would know that your user is a medication user. Your user is not someone who doesn't use medications or who uses maybe one medication every day that they're actually pretty compliant with. Know what their needs are. This seems so simple, but in my experience, it's the biggest thing we're missing in terms of how we're building M healthcare. So again, I'll leave you with this slide, is that to make an impact, in my opinion, we need M-Health to be M-Healthcare. And part of that is actually defining who our end user is in the M-Healthcare space. Thank you very much.
So, a few moments for questions.
It's not a question, but a comment. I'd just like to thank you for bringing this to the attention of all of us. This is the first time in 2 years that I've actually had the opportunity to hear a presenter speak specifically about the needs of older adults who are oftentimes invisible and marginalized, and I think it's particularly salient to all of us here, and thanks so much. Good job.
Thank you.
I was most interested in your comments about designing something that the user, who is the patient, enjoyed and the provider felt was not necessary and useless and frustrating. So we're working on an app that's communicating between patients and providers in the outpatient space, and we're running up against this as well, where the provider doesn't want an additional login, doesn't want another, quote, EHR to deal with, but we really want to bring the patient voice to the provider. So could you talk a little bit about how you mediate between the needs of both sides and making it work for both sides?
This is my comment about failure before, things that I'm learning. We've started doing stuff where we have a couple of times a year events where we have about 30 people come, they do 5 and 5 presentations, and we get patients, professionals, developers in the room and try to talk about this. I think one thing I'm realizing is that I have spent a lot of time looking at behavior change and prescribing behavior change in the past, and I'm not so sure that M-Health, M-Healthcare, is well designed for affecting behavior change. And for many of us in the healthcare sector, what we've been looking at is trying to change clinician behavior to meet the needs of patients. And I'm not so sure this is actually the right medium to do that. You need a lot more. We need to change our education. We need to actually change management in large institutions. We have to have local opinion leaders and buy-in. So I actually think how we're trying to mediate it is having more of a systems approach. We're in complex systems, so recognizing complexity, the opinion leaders, failing, a lot of failing. So I'm very much where you're at. I'd love to hear afterwards what you're doing. Maybe we can compare notes and have better ideas. Thank you very much.